What we have learned, especially in the last 6 months, looking at many studies that have been done and now completed over this period of time, is that from the 4 million people roughly that have died from COVID-19 disease, and many more that have suffered from severe disease worldwide, a substantial number of those severely affected patients have been suffering from diabetes or other forms of prediabetes and metabolic disease. So what is clear at this point is, in terms of medications that we are using in those patients that have not been vaccinated, those patients that still suffer from severe disease, that all of them will be treated with dexamethasone in severe inflammation, a substance, of course, that has anti-inflammatory power, but on the other hand will also affect glycemia, and we have seen quite a number of patients going into diabetic ketoacidosis and having severe aggravation of their diabetes. So monitoring of blood sugar has been an important point, and even milder forms have been treated with cortisone spray like budesonide. And again, we have to keep in close consideration that the blood sugars must be monitored, because we know that patients in the first place with diabetes hyperglycemia are at higher risk, but also if hyperglycemia occurs, other medications like interleukin-6 antibodies that we also have been applying now for severe COVID don't act properly. So what we first of all have learned is, and we have published work on this, but there are quite a number of publications now that confirm what we initially a year ago were just suspecting. So suspicion has become very clear evidence that COVID-19 or SARS-CoV-2 can infect indeed islets. So the islets, the insulin producing cells, express ACE2 receptors, functional receptors, also functional receptors for other viral entry such as DPP4, and viral particles could be shown in several high-level publications in autoptic in patients that died from COVID-19 in the pancreas. We've also seen single cases of type 1 diabetes developing ketoacidosis or presenting with DKA following infection. This may be a new form of diabetes in the rare cases, more likely in many cases an aggravation of a pre-existing diabetes. And this increased risk for diabetic ketoacidosis in diabetic patients with severe inflammation of any kind of infection is well known, but it has been even substantially more in patients with COVID-19 disease, because this virus uses metabolic pathways like ACE2 for acting in the cells and in the systems of the body. This is a very important point, as you are mentioning, how relevant are diabetes medications throughout the pandemic. Initially, there was a lot of confusion a year ago. People were suggesting that some medications may even be harmful, not so much the diabetic medications, but medications such as ACE2 inhibitors or ACE inhibitors, suggesting that they may even cause an increased impact on cells or viral entry. All of this we know now over the pandemic, and especially in the last month. Of course, all of these medications should be continued. It is clear that management of blood sugar, management of blood pressure is very important also as a preventive mechanism for severe disease. So what we learned that in very severe disease, we would not recommend giving metformin for the danger of lactate acidosis. But all the other medications, SGLT2 inhibitors, for example, may be a danger of people getting too dry, of losing too much fluids. But in general, continuation of these medications has been a clear recommendation in our recommendations and also updated recommendations. And there was also a suggestion that possibly DPP4 inhibitors, as the virus uses the DPP4 system as viral entry, may be protective, may even be a treatment of preventing severe viral infection. This has not been proven so far, but what we know is that the continuation of DPP4 inhibitors is safe and is appropriate. Similar thoughts have been in discussion for metformin, that is known to be anti-inflammatory and has possibly antioxidative, anti-cell death effects, that this may be also a protective factor. Here, research is still open, but it's clear that continuation of these medications, unless there is a very severe form that needs intensive care, is appropriate. And other than that, of course, in the patients that we had on intensive care units, insulin was the treatment of choice, and blood sugar monitoring as well in the intensive care unit settings. First of all, diabetic patients are a risk group, and they should have been the first to be vaccinated or among the privileged groups to be vaccinated. In reality, this has been a problem in many countries. We have known before from several other vaccinations programs like influenza and others, that especially this group, the group of diabetic patients, are sometimes from difficult social background and is a most vulnerable group of patients that are evading or are not good at adherence to vaccination programs. So again, we are seeing that there needs to be a bit more effort by practitioners to make sure that their diabetic patients are vaccinated. And I'm still shocked that in many countries, those that should have been the first seem to be the last. And it's not only due to neglection, but it's also a state of mind, a certain reluctance, skepticism towards the vaccination program. We haven't seen more side effects at this point that may be associated with some of the vaccinations in diabetic patients. We are also not aware at this point that diabetic patients who are indeed immunocompromised would evade or would fail with the double vaccination. But this needs to be monitored, and we need to look at this more closely. There are dramatic gender differences independent of diabetes between females and males, and we also have to explore if possibly the diabetic patients then need to be the first getting the third jab, meaning getting the third boosting vaccination earlier than the others. But this is open and currently under review and has to be analyzed. So it has become very clear in the last 6 months that, and that should direct your question of prioritizing and priority, that not only patients who have had diabetes before and have been infected and had a severe outcome should be monitored now also in the post-COVID phase, but also those patients that have not been infected, fortunately, and have now received, hopefully, their vaccinations in most cases, do have collateral damages. This is in increased weight, and we have seen especially 3 very vulnerable groups. One of them being the diabetic foot patients, of course, that have been neglected in an almost scandalous way. So there was a dramatic increase in major limb amputations in that time, and I'm very concerned that this will continue because still services are not running at full speed. A lot of not only the doctors but the entire health personnel are exhausted. Patients come in slowly and they come with forms of advanced disease, sometimes in a septic state, and this will lead to complications we have not seen before. And financing of these diabetes wards and facilities are not as good as we would like them to have. So this is one major point. Similar for the very obese. Those, as we know, have been another group of the most vulnerable. Diabetes with high obesity, especially also in younger people in the States, in South America, but also in Europe, has been a major factor for severely affected patients. And bariatric and metabolic surgical programs have been terminated all over, and there is a backlog. So it is important that those patients come back to their treatments and get their clinical care that they need. So the collateral damages are of major concern, and I think there needs to be a lot of effort for this part, as well as for the research of post-COVID complications that seem to involve not only pulmonary problems and chronic fatigue syndromes, but also numerous metabolic perturbations that need to be monitored and treated. I think what we've learned in the last 6 months, and unfortunately now with what is going on in the UK, with a relevant number of patients that have been vaccinated, but now do show, fortunately, not too many symptoms, but nevertheless infections with the new variants, that this pandemic will keep us busy for forthcoming years. And it is clear, and there is no doubt, that the group of diabetes patients, our diabetes patients and our metabolic patients, are the most vulnerable group through all, from childhood up to the very old. And we need, aside from exploring the mechanisms, finding new treatment strategies, finding the optimal vaccination strategies and vaccines for these patients, we need to also raise awareness that it is the wrong way now. Diabetes services, even before Corona, have been not adequately in most of our healthcare systems. Now making, after the cost involvement and after the Corona, cutting and shutting them down even more is a severe mistake. So it's a combination of exploring the scientific correlations, but also addressing politicians and healthcare deciders, stakeholders, that this cannot happen for the sake of our patients, as we have seen that these two pandemics, the existing pandemic of worldwide almost approaching 500 million of diabetic patients, and the communicable, the viral pandemic that were so intertwined and interacting, that this will need a combined health strategy for the future.